Welcome to Chronic Pain Gains in Alberta, an ECHO series. Thank you for joining us today. I would like to start this event by acknowledging that the ACFP is situated on the traditional and ancestral territory of many people presently subject to Treaties 6, 7, and 8. I make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on. Our agenda today is very simple. We go briefly through our disclosures and a few of our housekeeping items first. You can just flip the slide, Carrie. Well, oh, sorry, I shouldn't have flipped the slide so soon. So we'll start with a short 10-minute didactic presentation by Dr. Nancy Easton, followed by 5 minutes for questions and answers. We'll start our case presentation promptly at 5 p.m. We'll have 15 minutes for clarifying questions, first from the audience and then from our hub team. And we'll have 15 minutes for recommendations from our audience and hub team at that time. And we'll end with a summary and some wrap-up notes, and our session will be over today by 5:45. Now we can go to slide 4. We'd just like to start with our disclosures prior to our session. So my name is Leah Phillips. I'll be the facilitator, and I'm joined by our other ECHO coordinators, Kathy and Carrie and Jared, and we're all paid employees of the ACFP. Go to our next slide. So this program receives financial support from the Health Canada Substance Use and Addiction Program and in-kind support from the Alberta College of Family Physicians. Just like to acknowledge that Dr. Easton will be providing our didactic presentation, and she's been paid an honorarium for her presentation. And slide 6. Although we do our best to mitigate any bias whenever possible, this forum is discussion-based, and recommendations are those of the individual attendees. The recommendations from our didactic presentation, however, have been reviewed and approved of by the Collaborative Mentorships Network Scientific Planning Committee. So today we'll watch the chat for session. Please watch the chat for session instructions regarding the attendance and evaluation surveys. Our moderators will help you with any questions you might have. When asking a question, we do ask that you raise your hand and wait to be called on before we unmute you. And please just remember that ECHO follows an all teach, all learn philosophy. So that means that we all have something to contribute, and best practices is always to turn on your camera. And we strongly encourage anyone to participate in any way they feel they would like to. And if you have some clarifying questions, please raise your hand. If you don't feel comfortable, you can ask the question in the chat. However, we do prefer for you to unmute yourself and ask the question out loud. And yeah, from there, we'll just get started. Just to take a small moment to thank our support team. So our event support and our hub team, you've all been really invaluable for us for this last 6 ECHO sessions. So thank you so much. If you'd like to know more about our hub team, their bios will be posted in the chat section. And just a little bit of our library update. So this last week, we put together a selection of resources that followed from our ECHO session 2 weeks ago. And the one that we just will kind of bring attention to this week was it's called the Depression and Bipolar Support Alliance tool. So it's a nonprofit organization that offers education and resources and on bipolar and depression. And it's an American organization. However, I did find that the resources that are there are really excellent to go through. So it comes with a wellness workbook. So it's a way to be able to assess both yourself individually or as a provider's as a patient provider. It also has a goal tracker and then also a wellness tracker that goes through several months of time that you can put down information in about that. So if you would like to access any of our library resources, that can be accessed through this link that's on the page here, and that will be available for others after the session today. So I guess we'll just get to our main activity. So today's speaker is Dr. Nancy Easton, and Nancy grew up in Edmonton, and she completed her undergrad and residency in family medicine at the University of Alberta. Her interest in addiction treatment began with an elective at the Boyle McCauley Health Centre. There she witnessed mentor family doctors providing evidence-based patient-centered addictions treatment. And after graduating, she went back to work at the Boyle McCauley Centre, and she currently works there now. And since March 2020, she has provided addictions-related care in an inpatient setting at the Edmonton Isolation Facility, where she's established, it's established to provide a safe place for people experiencing homelessness and during isolation and from the COVID pandemic. In addition, Nancy is interested in women's health. She teaches students and residents at the University of Alberta. She enjoys the complexity, joy, and opportunity of providing addictions treatment to patients within their medical home. She enjoys being outside and gardening with her friends and family. So welcome, Dr. Easton. Now, and we will let you get going, and thank you very much for presenting.
Thanks so much for having me. And thanks everyone for joining us on this rainy day in Edmonton anyways, probably rainier in Calgary from what I hear. So as Leah had said, I'll be presenting on the signs of opioid use disorder in patients who are on prescribed long-term opioids, and pearls around how to manage patients on long-term opioids when you think that they might have opioid use disorder specifically. So as they mentioned, I'm being paid a small honoraria for this presentation today. I don't have anything else exciting to declare. The goals for the presentation, because it's a broad topic and it'll be a just brief one, we're going to review some tools for identifying opioid use disorder in patients who prescribe long-term opioids for chronic pain. We're going to identify what the first-line treatments are for these patients, and then we're going to focus on pearls for safe prescribing, harm reduction, and helping them move towards first-line treatments when they're not immediately ready for that initially. So I think we all are familiar with the gold standard for diagnosing opioid use disorder, which is the DSM criteria, 11 criteria. If you have 2 to 3 of the criteria, and unless the only 2 criteria that you meet are tolerance and withdrawal, then that would be considered mild opioid use disorder. 4 to 5 is moderate, and anytime you have 6 or more, considered severe. I find it's generally pretty easy for patients if they start to get a couple to meet 6 or more criteria. So I find oftentimes patients are being diagnosed with like severe opioid use disorder. Of course, it's the gold standard, and it is a really helpful framework for remembering the different behaviors and consequences that go along with opioid use disorder. But it is a little bit wordy and it can be time consuming. So other tools have been studied. One that we've actually discussed in some of our previous sessions already was the POMI, or the Prescription Opioid Misuse Index tool. And it's lovely because it's just 6 questions in pretty accessible language. I'm just going to quickly read through them because I don't think we've actually read them out loud. But so it's, do you ever use more of your medications? That is, take a higher dose than is prescribed for you. Do you ever use your medications more often, i.e. shorten the time between doses than is prescribed for you? Do you ever need early refills for your pain medications? Do you ever feel high or get a buzz after using your meds? Do you ever take pain meds because you're upset or using the medication to relieve or cope with problems other than pain? And have you ever gone to multiple physicians seeking your medications? So if they get 2 or more answer yes onto 2 or more of these questions, and there is a pretty high chance of opioid use disorder. Of course, this is a case finding tool, so it's not diagnostic, and you would definitely still want to explore the actual DSM criteria with them, as well as everything else going on, situationally in their life at that time before you made a formal diagnosis. If they answer no to most of the questions, and they don't answer yes to 2 or more, then it's also moderately effective at ruling out opioid use disorder, at least at that point in time. But of course, we know that opioid use disorder is only like one risk of long-term opioid therapy to be watching for, and you would still be monitoring for other complications in that case. I think in terms of using this tool, probably in the sort of current political climate, a lot of us these are probably pretty intuitive red flags for most of us. I assume a lot of us are working in primary care, and usually our spidey senses are going off if we see that there's double doctoring going on or people are requesting early refills. But as we saw in the case last week, this can still be a helpful tool even as a gateway, like to initiate a discussion with a patient. It can be nice to have something concrete to go over with them. Some people will use it for case finding, I think, in all their patients who are on long-term opioid treatment, and that's certainly could be reasonable as well. I also find sometimes I'll use it with learners just to kind of prime them before they're seeing a patient for some of the things to be on the lookout for, rather than just going through the DSM criteria in this really mechanical fashion. Sometimes these can be, nice things to ask about that can feel a little bit more organic. I find in particular question 5. So that's the one where it's talking about taking their pain meds to deal with emotions. I find that question can be really telling, because a lot of the time, especially new patients, might not be super forthcoming, and they know, or they've sort of almost been trained to not tell me that they're taking more than they're being prescribed, or not tell me that they get a buzz from their oxycodone. But if I ask a question like, you ever find sometimes you just need the meds to like help unwind when things are getting really stressful? A lot of patients who have answered no to other questions will really strongly endorse that, and it can open up the door to further discussion about what that might mean. So let's say you go through these tools and you really think that they do have opioid use disorder. Now what? So if we were in medical school, it would be super easy on an exam. We know that which is increase the dose of their prescribed opioid or preferred opioid in order to meet their increased tolerance. We know that that's a little bit like pouring gas on the fire in opioid use disorder. In terms of B and D, we don't have like RCTs, unfortunately, that I'm aware of, but we do have observational data from several sources that shows that when patients detox from their opioids without transitioning to long-term OAT, there is an increased risk of death, which is not ideal. So that pretty much leaves C, which is switching them to buprenorphine naloxone, and it would generally be considered the first-line treatment for opioid use disorder for most patients in evidence-based guidelines today. So again, if this was an exam, you'd circle C, you'd pat yourself on the back and move on to the next question. If only it were that easy in the real world. So this is where it starts to get murky. Addressing your concerns with them can be, challenging and emotional sometimes. I apologize, some of these suggestions are going to seem really vague. They're just pearls that when I polled different people in my clinic with patients with addictions, sort of longitudinally, suggestions that they had. So choose the right time or times. And I say times because oftentimes I'm going to be slowly introducing this concern over a couple of visits, because I have the luxury of seeing these patients long term. Especially if this is a patient who's been on this treatment for years and years and years, it can be significantly less jarring to just slowly, bring the visit up, bring the concerns up at one visit, and then come back to it over time and give them some time to kind of like percolate those ideas between visits. If the patient is feeling stressed or defensive for any reason, it might not be a great time to bring it up. Of course, I think we all know that. Or it might be a time to just like bring it up very briefly, plant a little tiny seed, and then, give them some space to process that. But at the same time, don't avoid it, because we know that this is a chronic progressive illness that is often fatal. And so we really want to intervene as early as we can, even if it means having difficult conversations. And sometimes we're pleasantly surprised. Like, I'm sure we've all had conversations where we went in dreading it, and the patients were actually like equally concerned, and were almost relieved that we were bringing this up and that they had a chance to talk about some of the things that they've been noticing with their pain medications. So however they react, whether it's better than you expected or not so much, I really try and ground the conversations just in the fact that I care about their well-being and their safety. And I think anyone here would do this, but or I don't think anyone here would do this, but sometimes the conversations can, at least to the patient, come across as a little bit almost accusatorial in nature. kind of like we're busting them for having opioid use disorder, almost like it's like instead of pain, they have this other thing. And so I really will reassure them that I'm still very much aware of their pain and really wanting to help them manage their pain. And this just is an additional diagnosis that complicates that treatment. It's not a perfect example, but I sometimes think of it as we imagine like a patient who developed diabetes as a side effect of their psychiatric medications. And, we get that A1C back and we're like, oh, sure enough, there it is. We don't ever feel like we're busting them for having diabetes. That would just seem so silly. And we wouldn't immediately discontinue their psychiatric medications just because we got that A1C back and we're like, oh, diabetes, time to switch medications. Instead, we're trying to just help them manage this new condition. And there's a really good chance that that is going to involve changing some of their medications over time to better options that are more appropriate. But we're coming from a place where we realize this is a complicated situation and it's going to be difficult and take time to address. So next slide. The one thing that makes it unfortunately so much harder than talking to someone about diabetes is that there's so much stigma around any addictions, and probably opioid use disorder is a particularly stigmatized one. I'll try and address the stigma really proactively. And I think just the biggest pro with this is I think everyone here knows that opioid use disorder and addictions in general are terrible illnesses to live with. They cause a lot of suffering and no one would ever choose to have them. And it's in no way a moral failing, which we all know, but the hard part is making sure that they know we know that and believe that, and then helping them to sort of come to terms with that for themselves. Because we've probably all seen that, patients with opioid use disorder, they carry a lot of self-loathing and guilt a lot of the time that, aside from just like contributing to their suffering and being a horrible feeling to have, can also impair recovery. So being trauma informed with all of these patients is extra crucial. We know that particularly, if you go to the next slide, exposure to trauma in childhood seems to play a big role in priming the brain to develop addictions later in life. And there's so much fascinating research going on around this, some of which led to the development of the ACEs survey that we've talked about in previous weeks. We won't have time to talk about it at all, but I would really recommend folks, when they have a chance, check out the Alberta Family Wellness Initiative. If you've never been there before, they've got lots of really good resources, from like really catchy 5-minute videos that can be helpful to show patients or family or colleagues, to a whole free 30-hour brain science course that goes into some of the research in a little more detail, and is also pretty layperson friendly. So once you've addressed the diagnosis, we can go to the next slide. The next step is discussing treatment options. And the peer group who presented last week have made a really handy guideline for treating opioid use disorder in primary care. So check it out if you haven't. It recommends buprenorphine, naloxone, and methadone, and it outlines some of the factors that would influence the shared decision-making around either of these. Oh, sorry, I just saw a snippet. Laura, were you asking about the course? It was, because I'm on 2 screens. Yeah, thank you, Leah. Sorry, I'm on 2 different screens, so I only see half the chat box. Feel free to interrupt me if there's something pertinent in the chat that I'm missing. So hopefully they want to explore one of these treatments, and a lot of patients are going to be appropriate for buprenorphine. The guideline does a really beautiful job of walking primary care providers through how they can provide that right within the patient's medical home. And there's also recorded workshops from Dr. Jess Kirkwood on this that are really excellent. If the patient prefers to start methadone, if you don't have approval from the CPSA to start that, there's a list of different OAT clinics on their website. If you need like really timely one-time advice, you can get that through Rapid. There's lots of different options. And I always just encourage people to remember that even if they can't start someone on methadone, oftentimes once the patient is stabilized, they can get approval to maintain them so that then they can come back to the medical home if possible, if that's what they want. Okay, so ideally they want to start buprenorphine or methadone, but maybe they don't, especially not right away. If you want to go to the next slide, this is where even the next slide actually, sorry, I'm one behind. This is where it becomes just a really challenging balancing act, and almost like a completely evidence-free zone. It involves a lot of motivational interviewing, a lot of rapport building. Hopefully everyone was able to see Sasha's presentation on motivational interviewing and a few sessions back. And if you haven't, I definitely recommend going and watch that because it's extremely pertinent for this. Some brief pearls, I guess, they're pretty intuitive, but you don't want to make their care contingent on how they choose to manage their opioid use disorder at that time. Don't cut them off or force them to switch to buprenorphine and naloxone initially, but you do want to ensure that you're prescribing as safely as you can, and you're practicing harm reduction. And remember that it is okay to say no sometimes if you have genuine safety concerns that the treatments that they're asking for are going to pose a significant safety risk or make their health worse. So in terms of harm reduction, really we're incorporating this even if they are on buprenorphine, methadone, but things like decreasing the risk of overdose by mixing with other substances like alcohol, making sure that they're not using alone and that the people who are checking on them have and are trained on how to give naloxone, just because overdoses do happen so quick. Patients often don't realize that they can not typically give themselves Narcan, that they actually need someone else down there with them to administer it. Make sure patients know where to access clean supplies. And sometimes even if they don't acknowledge that they're injecting, but you wonder if they might be, or, you can just kind of phrase it as like, even if you know someone who might benefit from this program, it's out there. Because sometimes, it can take a while for patients to start to, be more forthcoming about those sort of things. And make sure you're monitoring for complications like cellulitis, bloodborne infections, things like that. In terms of safer prescribing, you don't want to cut them off involuntarily or involuntarily taper their opioids, but I would encourage you to, again, just adjust their dispensing intervals. And sometimes when opioid use disorder is at play, that could even mean daily or witness dosing of the opioids, depending on the situation. Urine drug screens is a tricky one, and pill counts as well. It's a helpful tool, and I do use it sometimes, but it's another tricky balance because we know that at least in patients who are on OAT, there's evidence that using urine drug screens in a punitive way is actually associated with harms rather than benefits. So it's difficult to extrapolate this to patients who aren't on OAT because it's a different situation, but it is worth considering and just, I think, being intentional about how we use them. So as time goes on, hopefully you'll keep seeing this patient, managing all the other areas of their health, and sometimes that can help to build trust and rapport. I often find that this trust, along with hopefully increased stability in other areas, like maybe housing, combined with all the motivational interviewing that you're doing around their opioid use disorder, patients will eventually oftentimes move towards those evidence-based treatments that they initially were hesitant about. It's usually not going to be a linear progression, but oftentimes over time, that's the general direction that they'll be headed in. I think of it as like we're planting seeds. We're nurturing them, and we're just hoping that some of them will take root over time. As you go along, documenting things is extra crucial because these patients are so off-label, I guess, and there is no great guideline, unfortunately, for how to manage them. And yeah, every situation is unique, so just never be afraid to discuss management with colleagues, sometimes repeatedly, and get fresh ideas, perspectives. This is where I'll pitch the Collaborative Mentorship Network as a really great resource if you are looking for more folks to discuss approaches with. And I think in terms of my take-home messages are pretty short and sweet. Prevention is the best medicine, but early detection is the next best. Remember, we're not catching a patient who has opioid use disorder, and just focus on safety and care in all your conversations. And I think that leaves a little bit of time for questions. I tried to rush through that as fast as I could.
Thank you so much. I think we do have about 5 minutes for questions, and just wanted to say I really love the metaphor of planting a seed. I think that's really lovely. So, but please, our audience, take a minute to ask a question if you can.
It's tricky because I think a lot of this is intuitive. Like, it's hard to do. We know what to do in theory, but it's just hard, but it's intuitive too.
So Nancy, there's a comment in the chat. Ricky Schmidt's working at the Medicine Hat Recovery Center and just was talking about seeing a lot of successful transition for chronic pain patients to Suboxone or Sublocade. So just another example of where you can use this in chronic pain patients. My one question is actually to Ricky, are those patients with opioid use disorder? I'm presuming so, because they're in the recovery center. They're chronic pain patients with opioid use disorder?
Actually, no. So we get a lot of requests from chronic pain patients that have no history of illicit opioid use. But as we've indicated with Nancy's presentation, several of them have actually developed an opioid use disorder out of no fault of their own, just based off of how intrinsically overwhelming and dependent their use of prescribed opioids has become. And so I have a client in our care currently who is on a fentanyl patch, Percocet, and Tramadol daily. And we're in the process of rotating her over to a single dose of Suboxone. And so we've done dozens of individuals with no fentanyl use, no heroin use, but it's an eye-opening experience for them coming into our center because they don't see themselves as users, right? And so we just normalize the idea of we're all here and we're all dependent on something. It doesn't matter how we got there. But yes, a lot of AHS detox facilities around the province are providing that service. So it's definitely something to collaborate with if you're looking to start the Suboxone in a supported and medically monitored environment, which can be helpful for sure.
Yeah, great. Thank you. And so another question from Janet Craig. She's asking for suggestions for medications if you've got mixed alcohol and opioid use disorder. Any advice there?
So alcohol use disorder and opioid use disorder, not just chronic pain, but opioid use disorder. Yeah, the safest would be buprenorphine, just because of the ceiling effect. It's not impossible to overdose, especially if you're mixing it with alcohol or benzodiazepines, but it would be significantly safer even than something like methadone if there's alcohol in the picture.
Great.
And just lots of harm reduction counseling.
Laura, did you? Yeah, Laura had a question too, just we don't want to miss her.
Laura, do you want to unmute and ask that question?
Sure. Thanks so much, Nancy. I mean, the tension between daily dispensing or even blister packing or weekly dispensing and whatnot, and the financial costs, but also the time burden of that for so many of our folks. Do you guys have a integrated pharmacy at Boyle McCauley, or how do you overcome some of those costs?
Yeah, so we don't have an integrated pharmacy. Most of our patients have coverage unless they're seniors. So obviously there's a cost to the system that we still factor in, but it's not a direct barrier money-wise to the patient. Obviously the time piece is still there. Mm-hmm. I find oftentimes this can be where it can be an extra little incentive to switching them to Suboxone, to buprenorphine naloxone. because if I have a patient who has been getting like 3 months of, hydromorphine or, at a time for ages and ages and ages, sometimes what we used to do, I think, because we were all like nervous and addictions are scary and buprenorphine's new, is we'd say, go to the pharmacy every day and get your Suboxone. And now we're realizing like that's probably really silly. It's a much safer medication.
Yeah.
And so sometimes if they're on the fence, that can be actually for a lot of patients, something that pushes them in that direction. If I say, I'm actually going to feel much safer giving you larger amounts of medication, if that medication is Suboxone rather than the Percocet that you were on before, where I don't feel comfortable giving you 600 tablets at a time of that medication.
For sure.
But yeah, it's really hard. It's like a very tricky balancing act to do, especially if they don't have coverage. The other thing that can be helpful just for everyone to know about is in Alberta, there is a program called GAP coverage. I don't think we've talked about it yet. It covers Suboxone and methadone for several months outside of any other coverage. They just need to have an active Alberta healthcare number. And so even if you're in the process of getting someone on income support, it's going to help to bridge that time, and it's complete coverage.
And there's
It's GAP, G-A-P.
Yeah. There's
And
one more question.
Like sometimes they haven't heard of it. Sorry, Kathy, go ahead.
Oh, no problem. Just one more question from Dana Garden. What dose of Suboxone are you typically using for your chronic pain patients? And do you monitor LFTs in the patients with alcohol use disorder, given the increased risk of hepatic toxicity with Suboxone?
Okay, so sorry, the first one was, let me just go back in.
What dose do you
start? Really depends. To be honest, like in my setting, most of my chronic pain patients also have higher tolerance from fentanyl use, and even if it's not every single day, like it's just so out there and so common. So oftentimes by the time they get to me, they have that higher tolerance from that. So then, we will often see people, typically they're on doses of higher than 16, not always, but typically more than 16. And as we've discussed before, oftentimes the split dosing can be really helpful for analgesic effect from the Suboxone. And then in terms of liver enzymes, I'm not really monitoring for that because of the Suboxone. I think if someone had active, liver disease and they were still drinking, then I'm certainly monitoring that the way I would anyways, but I'm not necessarily saying, oh, now that you're on Suboxone, we have to really like ramp up the number of LFTs we're checking. I would just sort of do like an APRI score on them, once a year or something to kind of monitor for them to develop cirrhosis. So that if they had cirrhosis, of course, we would do the HCC screening. Just me.